Good afternoon, everybody. I am Margaret Donahue from the Veterans Health Administration. I am a family physician, board-certified clinical informaticist, and the director of the Veterans Health Information Exchange, also known as Wheeler Health to many people. I have with me some of my colleagues that work hard on this program with me. Joe Nelson, who runs our community engagement program, Leanne Rolling, who runs our partner outreach program, and Frank Amoruso, who is very active in our direct messaging program. So we have multiple pieces to our program. What I'm going to do today is talk a little bit about the history of the eHealth Exchange and interoperability at the VA. Then I'm going to talk a little bit about what we're doing right now and our current status, and then get into some of the future of interoperability at the VA, much of which you can see by visiting our booth here to my left. There's a lot of amazing work that's being done at the VA around interoperability today. So I think, the value proposition is something that all of us who are working on interoperability understand. That there is really an enormous opportunity here to improve care for veterans and all patients across the nation. How are we really going to improve the coordination of care across the continuum, improve the efficiency of care by reducing test duplication, and really improving the quality of care in general by making sure that clinicians have the information they need to make the right decisions for veterans. And then finally, we're very interested at the VA in empowering veterans. This is all about our mission of really providing the best care for veterans. And veterans are at the center of interoperability. They are a piece of what we do, and I'll talk about that some as well. So we right now have three major focuses in our current state of interoperability at the VA. We do VA Exchange, which is a query-based exchange, where a VA provider can query and receive information from across the nation from our community providers, and that is a bi-directional exchange. And then also VA direct messaging, which is, as many of you know, an email-like secure national standard for exchanging health information provider to provider. And then we support and are very excited about the patient-mediated interoperability that is happening with My Healthy Vet. That's our veteran patient platform. You can see the My Healthy Vet showed here in our interoperability showcase as well, and see some of the activities where veterans can actually download their information in standards-based format and send it through direct messaging to their patient portal at the USPS, United States Postal Service. So that's something that we're hoping to really expand broader so that veterans can send information where they want it to be through direct messaging. Here's a little timeline of VA query-based exchange. It precedes me by quite a bit, but not a lot of people in this audience. Tim Cromwell and Vanessa Jordan and Denny, there's a bunch of you here that were at the root of things back in 2006 when, the HHS really started working on interoperability standards for exchange. And the VA and the DOD and the SSA were very engaged in those early implementations. And then in 2008, the VA stood up its Connect Gateway with initiating production pilots with Kaiser Permanente, San Diego, DOD. Then in 2009, the Wheeler Lifetime Electronic record legislation occurred, and it became a legislative mandate that we figure out how to be interoperable at the VA. So we've been trying to meet that mandate ever since. We are doing a lot, though. We have amazing interoperability with the DoD, and as you'll see, we are really exchanging broadly across the nation as well. I'm going to go to the next slide. This is just a quick look at our growth. You can see that we're rapidly growing in terms of adding partners and exchanging documents at the VA. And I will go into those numbers a little bit more, but I will say that the VA is a major player in health information exchange across the nation right now. So this is the direct secure messaging timeline. And again, you know, we have a significant commitment to being able to use direct messaging to exchange information with our partners. This is becoming more and more important with our community care program. This is an important tool for referral management. And we also have implemented some ADT alert notifications through direct messaging and other use cases. But our direct messaging progress has been really picking up over the last 2 years as well. So that's sort of the background of where we have been. And right now we are in this point where we've got to do some major things to move forward. We are expanding so rapidly that it's really maximizing the capacity of our systems. And we do know that there's a real urgent need across the nation to show that interoperability is improving patient care, and we're doing a lot of work to try to show that value. And then we, as a program, spend a lot of time addressing our barriers, actually three major barriers, I think, to interoperability, and probably others are experiencing this as well. VA has some particular policy barriers, but also this need for expanding technology and really enhancing clinical adoption of the tools. So a little bit about the VA. I don't see it on this slide, but I will say that we are the largest integrated healthcare system in the nation. I think. Okay, and we have over 145 medical centers and over 1,000 ambulatory centers spread across the nation. And every single one of these centers has an important need to exchange information. We have 9 million enrolled veterans and are actively seeing and caring for over 6 million of these veterans, with almost 100 million visits a year and 700,000 inpatient admissions. So we are very active. And a lot of our care now is happening outside of the VA. It is estimated that 3 out of 4 veterans receive some kind of care outside of the VA, VA-enrolled veterans. And these numbers are growing quickly. So that you can see that this is our percentage of care provided to VA-enrolled veterans, and the amount of care that's happening outside of the VA is growing every year. So now it's 30% of the care that we pay for is outside of the VA. So the Veterans Health Information Exchange Platform is partnering with our community care program, which is responsible for the payment of care outside of the VA. And there's a lot of questions being asked now about how we really grow this network to reach all of our partners. There's something like 500,000 doctors right now that the VA is contracting with for care outside of the VA. And we need to reach all of them and be interoperable with all of them. So that's the question about how do we do this, really to achieve this concept of seamless care that the VA is very interested in reaching. So Again, our main tools at this time, query-based exchange and directed exchange. And our program approaches this through sort of 4 different tiers. We have 4 programs in our office. One is really focusing on our partner engagement. We have relationships with over 600 organizations across the nation. Leanne and Glenn Crandall, who's not here today, are very actively engaged with partners, meeting with partners all through this conference as well. We also have a lot of outreach to veterans. Again, Joe Nelson's program is really responsible for our veteran outreach. We have community coordinators across the nation in all of our medical centers who are educating veterans about health information exchange and gathering veteran consents for exchange. And then we really focus on how to make this a clinical tool, and thus our third P here for provider adoption. And that's really been my, sort of stick that I've really been, beating over since the time I came on board, that interoperability, to make it really work, it's got to enable the clinical workflow. Right now we're exchanging CCDA documents, which are a nice first step, but it's not a clinical tool. It's not something that clinicians can really use readily. And we need to be able to figure out how to get that data out of those documents and into the clinical workflow. So that's something we talk about a lot at the VA. And then finally, our technology systems that we manage. And this is just an eye chart here about our technology systems. Interoperability has many, many dependencies. Patient identification, our master patient index, our consent management, our terminology services, all of our viewers, including the Joint Legacy Viewer, which you can see over here in our showcase as well. Our data management platform, where the data is extracted from the documents and delivered into the workflow. So, and obviously the VISTA system itself. So there's many, many dependencies that we're integrated with. So just a few slides about our partners. And this is our map of our community care partners through the eHealth Exchange. We are very actively involved with the Sequoia Project eHealth Exchange, and we have 150 national partners. But those partners represent over 1,200 hospitals and over 30,000 ambulatory sites across the nation that we're able to do bidirectional exchange with. We are connected to over 20 state HIEs and working hard to get very engaged with the state HIE programs. We're connected to CVS, Walgreens, Kaiser, many of the largest healthcare organizations across the country. And we have now identified and correlated 1.8 million veterans who have unique veterans who have one or more records within our community partners. So those are records that are available for exchange. And here's a little bit of our growth over the last 24 months even. We are just growing by leaps and bounds. It's now about 100,000 incoming documents per month into the VA, and this is literally a doctor doing a query because we don't have prefetch turned on yet. And then in terms of outbound documents, we have 100,000 outbound documents a month. And this is a very small number of what our potential is, because we can only release information when we have a veteran's consent in hand at the VA. So I'm going to talk about this a little bit more, but that number probably should be 10 times that right now. And we have to figure out how to get there. Some of the tools that we are working on to onboard partners is our Fast Track program. We now can fast track Epic and Cerner into connection with the VA. And it's pretty much a plug-and-play process with both of those vendors at this time. We want to do that with more vendors and really encourage everybody to push their vendors to work with us to fast track with the VA. Our SSA program started in 2016, and they're now one of our biggest partners that we send the most data to for adjudicating benefits for veterans. And then our retail pharmacy program is a big program with Walgreens, where veterans can go to Walgreens and receive flu vaccines paid for by the VA that are delivered to us and actually incorporated into our VISTA database. Here are our direct partners. We have over 600 direct partners across the nation, and this is rapidly growing as well. And there's you can see the growth of our direct messaging program as well. So, the way that we're really working on clinical adoption, besides making the data available to clinicians, we really are trying to focus on use cases. And obviously, just improving the exchange of information so people don't have to fax. That's a huge thing for our healthcare centers. We are also, as I said, supporting community care consults. We have a lot of community partners delivering results back to us through direct messaging, as well as closing consults by doing queries for documents through the exchange. I mentioned ADT event notifications before, and there's just many other use cases that we're implementing. So this is an important slide that can give you some idea about our clinical adoption. We have now, through our joint legacy viewer, where our doctors go to look at clinical data, the doctors or the clinicians at the VA are looking at non-VA data about 130,000 times a month. And they're looking at this more than they're looking at vital signs in the joint legacy viewer. So that's good to know. Our veterans are downloading. So this is the light blue bar there. Our veterans are downloading their CCDs at about the same rate, 130,000 times a month. Social Security Administration in the dark green. You can see that last year we sent over 1 million documents to Social Security. And then outbound to our partners is, last year was about 500,000. And again, that's only 10% of what it should be. And the reason for that, I'm going to just talk about a little bit now. We do have a requirement at the VA. We're an opt-in organization where veterans have to sign a consent before we can release information to our community partners. And although we have 1.8 million veterans correlated, we only have 300,000 veterans who have signed consent so far. So this is a big piece of work that this team is working on as well. Our community coordinators spend a lot of time identifying veterans who are correlated but haven't signed consents and really working with the healthcare organizations to contact those veterans. We market through kiosks, through My Healthy Vet. We work closely with the medical centers to incorporate consent collection into the processes at the medical centers. But it's a lot of work to gather consents. And so what we're really hoping for is to approach this through policy and law. And we do have legislation now in Congress that we are hoping that will move us to an opt-out model of care that's consistent with what the DoD is doing. And I think it will really break wide open interoperability at the VA with community partners if we can get that legislation passed. So if any of you want to help, speak to your congressman and really tell them that you need the VA to move to an opt-out model of consent management, like the way the rest of the nation is. So this is a little bit about our wish to move to an opt-out model. In the legislation, it's part of the Veteran Care in the Community Act. Is that you out there, Karen? Yeah, okay. So that's being discussed right now in the Senate, and we're hoping that that will be passed for community care, but also for us. All right. Now, if we move to opt-out, and if we move to opt-out, obviously our need for increasing performance is going to escalate. We're going to be sending out a lot more information than we've ever sent out before. So we have really recognized the need to improve our platform and are actively moving to the HealthShare platform for supporting our scalability and over the next few years. So that is something that our team is working on. So I'm actually stepping into the future state, by the way. I forgot to tell you. Now we're talking future state. So future state, we got to get on a new platform. We're actively moving to a COTS product. HealthShare for starters, and where we're going in the future with, our overall VA modernization plan may take us other places as well, but that is our first step. The other thing that our team is really dedicated to right now is working on data quality. I really think that as a nation, there's a lot happening out there in terms of building this network with the eHealth Exchange and Care Equality and SHIC and Commonwealth. All of these organizations, all these networks are really coming together on a national level. And with TEFCA on top of that, TEFCA is the ONC's trusted exchange framework that they're hoping will enable all of these national networks to work as more of an integrated network across the nation. So if you have an AT&T phone, you can call someone on a Verizon phone. That's the same concept I think we're trying to get to with the TEFCA. So the TEFCA and the national networks that are out there right now, this is going to happen. We're going to have nationwide exchange. But if we don't get good data, this is really, I think, our biggest challenge. Is really how to make sure that the data that we're exchanging is really consumable and usable by our computer systems. So we at the VA have invested into a commercial product, the Diameter Health. Their booth is right over there as well. And we're doing analysis of all of our incoming documents and really trying to make more transparent to our partners their data quality. We're meeting with our partners, we're meeting with Epic, we're meeting with Cerner, and we're talking about CCDA data quality. And I think this is a big effort that is going to be happening in many of the networks across the nation too, that everybody's going to be talking about how do we make the data better. Another big area for the future that everybody's asking about is how do we really demonstrate value? So we're doing work around that in our program as well. The IPO is also working, the IPO, which is our interagency program, is also working on trying to demonstrate value around interoperability. And I think we have a lot of work, all of us in this area, to try to really show the value of what of this. And again, both the data quality and what we're doing around performance metrics are presentations you can see over here in our booth. So please stop by and see what we're doing around data quality, see what we're doing around performance metrics. And then I've already said this, but I'll just say it again. Reaching all of our partners is a big piece of work that we're doing. We're going to join everybody. We're going to join Care Equality. We're going to join Commonwealth. If Chic stands up their systems, we're going to be joining them too. The VA wants to exchange wherever we can to reach all of our partners for information exchange. And we are actually, our first step is going to be to join Care Equality via the eHealth Exchange, and that should be happening hopefully this year. All right. Finally, this one has a little rollout here. Okay. So we talked about data. Data is really important for interoperability. And, obviously, the data needs to be understandable. But finally is this concept of, seamless care. And I've been asking a lot about, what does this mean? What are we talking about, seamless care at the VA? So I think it really has to do with this concept that, you can't just send information here and there. It has to be quality data. It has to be data that can be removed out of its transport mechanisms. We can't stop at CCDAs. We can't even stop at sending a fire resource. I mean, the data needs to be extracted and utilized by our systems to really provide information for clinicians to empower their decision making, to drive clinical decision support, to support analytics and care management and population health, and to approach all of these things that we believe are so important in healthcare, but approach them from a global perspective where the data is comprehensive and really patient-centric. Okay, I think that's it. So any questions? And I have these guys up here too. If there's anything you want to ask about what we're doing about consent process or direct messaging or the health exchange or network expansion or data quality or performance measures, or we got a lot going on. So anything you want to ask, please do. Sure. Do any of my VA colleagues, John or anybody, you want to have any? Oh, and also the other thing here you can go see is our concept of Lighthouse, which is our digital veterans platform for where it's going to be our API platform for the VA as well. And they have a presentation over here too. And also the Healthcare Services Consortium platform where the VA is working very closely with them to really look at how we can use community data to enable these clinical processes and apps that they are sponsoring as well. So see what they're doing, work that the VA is very interested in as well.
Dr. Donahue, what are you or some of the panel members doing to build out to additional data domains so when you get that CCDA, it's fully complete with all the data domains, not just 20 or 30 or whatever?
Right. That's a really good point. I mean, I think as a nation we're pretty good at about 6 domains. They call them the PAMPI domains. And it's not enough. We all have to really work to get the depth of data quality deeper than those 6 domains. There's 15 domains that the VA right now is able to extract out of their Avista systems for our CCDA development. But if you look at what the CCDA can really transfer, it's around 70 domains of data. Really, what are we going to do about care plans? What are we going to do about what's the new term about the indices of health for, what do they call? Social determinants of health. Thank you. I need all the current lingo. But those are really important other criteria that we need to get standardized across the nation so that we can incorporate them into our documents or fire resources for exchange. The data that is outlined in the TEFCA, the UC, the US CDI, everybody should look at that. The comment period is over, but there, you know, the ONC is really trying to deepen the standardization of data that's going to be exchanged as well. So, and we're working with a lot of partners like InterSystems to help us, and Diameter Health to help us to really take our data and get it, improve it and normalize it and be able to incorporate it into our documents as well. Anything from community care? Nothing. We're here to serve you. Yes.
In data quality, what kind of problems are you seeing there? Can you speak more about that and what you're doing to resolve it?
I need another color friend up here. Sandy? Can you hand her the microphone right here, our data quality expert? You want to answer that question?
So who asked the question? Because you were behind. Right behind me.
What kind of problems are we seeing in data quality?
So we see trending at the vendor level, that for all vendor one, we see certain commonalities. And the great thing about that is sometimes we find a one-off, and that's just a configuration setup for that particular partner. And then so that's a site level. So there's a vendor level, there's a site level, and then there's a workflow level. Because we find that in vendor C, the workflow has great data being entered by clinicians where it works for them, but it doesn't end up in the right place in the architecture. So it doesn't come through in the CCDs. So what we do is we develop a presentation with all of our observations, and we go back and talk to vendor level or partner level, and we talk about here's unique IDs, you can go back and find these examples and start to do your own troubleshooting. So we have a sustainment process where we show metrics and our observations, and on the other side we inform people who are going to use it for clinical rules or COTS or, you know, the number of transformations they may need to make given that this is the quality of data that's coming in from a partner. So it's multi-level. And as we scratch, then we realize an HIE wants to hear about specific stakeholders, not just randomness. So, you know, the partners are teaching us as we present to them how to do it even better. And they're all enthusiastic. They're all ready to go and start the research, so it's great.
And part of the problem right now is just the lack of standardization. Everybody's doing it a little bit different, and so the more I think that we can, you know, the VA is in a unique position, I think, of really elevating the conversation to really talk about how we can make information incorporated more consistently into our exchange formats. Should we stop? Anybody else? All right, thank you very much.
Very good.
Thank you.